على الاي سي يو مانجمنت. دكتور احمد معانا؟
معاكم.
اتفضل.
السلام عليكم. الأول أنا بحب بس أشكر الدكتور طه إسماعيل والدكتور محمد الشافعي والدكتور هاني طبعا أستاذي. Good evening everyone. Today I would like to thank organizing committee. I will talk about COVID-19, mainly ICU management of COVID-19 patient. This is Ahmed Zahra, lecturer of critical care medicine at El-sheikh University. This lecture will talk about small hint about COVID-19 novel series management take-home message. I have no conflict of interest. COVID-19 is an infectious disease caused by recently found virus known as SARS-CoV. Before the outbreak originated in Wuhan, China on December 2019. Is genetically similar to SARS coronavirus causing MERS, spreading by people and from person to person, and small droplets land on surfaces. There is many symptoms range from asymptomatic people to mild and moderate cases up to severe critical cases. Mild infection, about more than 80% of people does not have symptoms. The symptoms range from fever, cough, shortness of breath. Mainly, I would like to concentrate about taste or smell disorders. This paper last updated at 10 April 2020 by Jennifer Papek, mainly concentrated of fever, myalgia, cough, dyspnea, and taste or smell disorders. Fever about more 75 of patients. Myalgia about 50%, respiratory cough about 80%, dyspnea about 50%. Cardiac multiple cases reports of myocarditis. Labs biomarkers, CPC mainly 80% leukopenia and lymphopenia and about 20% lymphocytosis. Microbiology, it is important issue to diagnose co-infections can occur with COVID-19. Imaging chest X-ray in all patients. Clues to COVID-19 is about bilateral ground glass appearance, mainly peripheral distribution. COVID imaging is starting with ground glass appearance. CT chest show alveoli filling with fluid. Severe cases, infections, consolidations, white patches, crazy paving pattern. This is swelling of interstitial space. These images show ground glass appearance, consolidation, and crazy paving pattern of COVID-19. Usually not seen in COVID-19 pleural effusion, large lymph nodes, large cavities. Disease severity caused by cytokine storm leading to severe lung damage, ARDS, mainly septic shock, mainly in the patient more than 60, high-risk people more than 60, smokers, previous medical conditions, same like diabetes, hypertension, and so on. Cytokine storm is a hyper-inflammatory state characterized by fulminant multi-organ failure, elevation of cytokines, mainly ferritin more than 500 microgram per deciliter, elevated B dimer more than 1 milligram, CRP more than 100 milligram per deciliter, LDH more than 25 unit per liter, lymphocyte count below 0.8. Another laboratory criteria, it is neutrophil lymphocyte ratio more than 3.13. COVID-19 associated with coagulopathy causes DIC lagging picture, too much clotting and too little clotting, also leading to lung microthrombi, were reported in autopsy. Cardiac complications, same as myocarditis and myocardial infarction. There are three series according to surviving sepsis campaign guidelines. COVID-19 pneumonia, same like ARDS. Gatinoni group classified two phenotypes according to lung pathology type L and type H. Type L consists of low elasticity, normal compliance. Type H, high elasticity, low compliance. Novel theory, pulmonary microthrombi, endothelial dysfunction, hemoglobinopathy. According to intensive care medicine, Gattinoni group classified the different respiratory treatment dissociation. They found the association between patients relatively well-preserved lung mechanics and the severity of hypoxemia. Type L, we found in this picture mild infection, not severe infection, characterized by low lung elasticity, low ventilation perfusion mismatch, low lung weight, no need for recruitment. This picture shows normal lung, slightly bronchopneumonia. Although PaO2 over FiO2 hypoxic index is a hypoxic index, we measure PaO2 over 52, about 95. So that is to say, this picture is as severe ARDS. Although the picture is normal or nearly normal, but the patient complains of severe ARDS and severe hypoxemia. Later on, severe inflammation and increased negative intrathoracic pressure by spontaneous press allow patient self-injurious lung injury, inflicted lung injury, without increase extra volume lung, increased collapse, increased pressure, leading to respiratory failure. Phenotyping H, high elasticity, low compliance, high shunt right to left shunt, lung weight is heavy, high need recruitment. Comparing between type L and type H. Novel theory, another novel theory, pulmonary vascular thrombosis and endothelial dysfunction. COVID-19 increased interleukin 6, platelet activator inhibitor 1. COVID-19 holding ACE inhibitors increase platelet activator, plasminogen activator inhibitor 1, sudden thrombotic surge leading to microvascular thrombosis and macrovascular thrombosis leading to cardiomyopathy, arrhythmia, acute kidney injury, and death within 48 hours. We can use TPA or heparin or anticoagulation. I will talk later about it. Another theory, endothelial dysfunction, silent severe hypoxemia with normal compliance, radiologically early patches, ground glass opacity, sepsis-induced coagulopathy score. We found DD dimer high and fibrinogen level is low, FTPs is high, coagulation profile is prolonged. By echo, we found left ventricular dysfunction, systolic and diastolic dysfunction, postpartum autopsy, disseminated intravascular thrombosis in lung, heart, kidney, and brain with endothelial damage. Hemoglobin, COVID-19 attacks beta-1 chain of hemoglobin, capture profiling to inhibit human heme metabolism, according to China references. Management. We know that COVID-19 is a virus, so antibiotics do not work against coronavirus, except if the patient has a secondary infection. Infection control, performing aerosol-generating procedure, same like AMBO, we recommend using FPP2 or N95 respirator. We, especially in a negative pressure room, the best practice is statement. Non-ventilation patient, patient is not on mechanical ventilation and the non-aerosol generating procedure. We can use surgical mask only, not N95, plus personal protective equipment of weak recommendation and of low quality evidence. How to manage airway problem? First, planning, aiming to avoid emergency intubation in negative pressure room. Senior clinician is found. Early airway assessment. Prepare about 5 to 6 person airway team. Use COVID intubation tray. I will talk about it later. Using PPE, hand hygiene, donning hand hygiene gown, mask, eye protection, hat, or face shield. Pre-oxygenation, keep the patient head up position about 45 degrees. Pre-oxygenate with using two hands. And we can also get untitled CO2 performed by using video laryngoscope, but not found in many hospitals. Post-endotracheal intubation do not ambu the patient before inflating cuff. And COVID intubation tray, this is a negative room pressure. There are 4 patients, 1 runner, team leader, airway operator, must be an expert in intubation, airway assistant, outside runner, airway trolley, bronchoscope, cardiac arrest trolley. COVID intubation tray, Macintosh video laryngoscope plate, another plate, Macintosh endotracheal tubes with different size range, Poggi stylet 10 ml syringe, tube tie, lubricant, viral filter. We should consider a viral filter, endotracheal, endotracheal CO2 to check if the tube inside the endotracheal tube or not. Nasogastric tube, we inline suction. Ventilatory strategy. Now we deal with COVID patient with hypoxia. If this patient for endotracheal intubation or not. If he is for endotracheal intubation, go for endotracheal intubation. Do it by expert using personal protective equipment with respiratory N95 respirator. We try to minimize stuff in the room. We consider if available video laryngoscope. If the patient is not indicated for endotracheal intubation, try to use supplement oxygen, first with oxygen mask with 5 liter oxygen, then try to use, if failed, a non-breathing mask up to 15 milliliter oxygen. If the patient is not tolerated, we consider high flow nasal cannula and is not found in our hospital, and mainly in hospital. Many hospitals not found high flow nasal cannula. Try to monitor closely, target oxygen saturation range from 92 to 96. Appropriate infection control by using N95 and negative pressure. If there is no availability for high flow nasal cannula, we can use non-invasive CPAP, but we not recommend to use non-invasive CPAP to aerosolar infection. Which mode we can use it? If the patient have mild ARDS, we can use a pressure control mode. As the patient have restrictive lung disease, same as the ARDS, we can use volume assisted control. What I mean by volume assisted control is that's to say deliver specific volume at certain rate. Pressure will be variable, volume is a constant rate. Invasive mechanical ventilation, we classify the patient with mild ARDS and with moderate severe ARDS. Mild ARDS, we put tidal volume about 4 to 8 milligram per kg and plateau pressure below 30 centimeter water. To investigate for another bacterial infection, make target oxygen saturation range from 92 to 96. If the patient has moderate to severe ARDS, consider the same previous settings with higher PEEP and using neuromuscular blocking agents, and consider prone ventilation up to 16 hours. We consider non-invasive, inhaled nitric oxide and veno-venous ECMO or referral to ECMO center. Another ventilatory strategy, type L, that consists of high compliance, so we can increase tidal volume to 8 milligram per kg. And type H, we have a low compliance, we can use low tidal volume as a protective lung strategy theory. Diagnostic test. We have the patient in ICU on mechanical ventilation, so we recommend to use lower respiratory tract sample in preference to upper respiratory tract sample, same like nasopharyngeal or oropharyngeal. With regard to lower respiratory samples, we can do it by endotracheal aspirate, better than bronchial alveolar lavage. hemodynamic monitoring. We have static parameters and dynamic parameters. We recommend the use of dynamic parameters, same like as capillary fill, passive lake test, serum lactate, pulse volume variation, stroke volume variation, rather than static parameters, same like central line. A conservative fluid strategy, better than liberal fluid strategy. We recommend using crystalloids, not to use colloids. We against using heterostarch and so on, gelatins and dextrans. We against use routine of albumin. We also we only use albumin if the patient shocked. We can first line to use is a norepinephrine. If norepinephrine is not available and if the target mean arterial blood pressure not obtained, we can use a vasopressin or norepinephrine as a second line. Strong recommendation not to use dopamine also. If the patient have a cardiac dysfunction, whatever, left ventricular failure or sleep failure, we can adding dobutamine. In the refractory shock, we suggest using low dose of corticosteroids, about 50 milligram IV Q6. COVID therapy, we have hyperimmunity, same like immunoglobulins, passive immunity, convalescent plasma, hydroxychloroquine, zinc in 4, favipiravir ده اللي هو الRNA polymerase inhibitor, ritonavir, tocilizumab, anti-interleukin 6 antibodies, steroids, anti-inflammatory, anticoagulation. In mechanical patient, we try to use antimicrobial and antibacterial. If the patient shocked, we can use antifungal. For fever, we using acetaminophen or paracetamol. We against the routine use of standard intravenous immunoglobulins and against use of convalescent plasma. Against routine use of ritonavir, ritonavir, when sufficient evidence to use antiviral agents in critically ill patients with COVID, same like hydroxychloroquine. Insufficient evidence about using recombinant interferon and hydroxychloroquine with tocilizumab. It is an anti-interleukin 6 antibody. According to National Health Society of Imperial College Health Care, if the patient D-dimer below 100, we can use a prophylactic enoxaparin according to the body weight. If the D-dimer range from 1,000 to 3,000, we can use as therapeutic anticoagulation. More than 3,000 tizanaprin, same like NOHEP in Egyptian market. Before home message, I want to highlight on Egyptian protocol. According to symptomatic patient, we can asymptomatic give only soltenavir, Tamiflu, 75 milligram once or twice daily for 5 days, and using cyanocobalamin and ascorbic acid. For mild cases, just upper respiratory tract, use all same treatment plus hydroxychloroquine, 400 milligram Q12 for 1 day, then 200 milligram Q12 for other days. In severe cases, we use the same treatment plus azithromycin or clarithromycin, plus using according sepsis protocol, subscribing sepsis campaign protocol. Take home message: wash your hands with an alcohol-based sanitizer. Keep a distance at least 1 meter between yourself and anyone who coughs. Try your best not to touch your eyes, your nose, and your mouth. Cover your mouth and your nose with your bent elbow or tissue when coughing. Seek medical attention if you have difficulty breathing and high fever. Follow the direction of your national or local health authority. Thank you for questions.
شكرا على المحاضرة الجميلة دي. كتر خيرك إن حضرتك موجود معانا النهارده بعد الأونلاين انترناشونال ميتنج.